Tonight we're going to be discussing the topic of anaemia and PKD. We know all too often it is something that's discussed and not many of us understand it, so there's always questions arising. So tonight on the call you have myself, and it's myself you've been corresponding with. I'm Susan Muirhead. I am the Support Services Manager here at PKD Charity. I'm joined tonight by Alison Taylor, our CEO. Good evening, Alison.
Good evening.
And also our guest speaker, Anne Crompton.
Hello.
Anne Crompton has kindly spoken before. She's well known to the charity, and she is a kidney specialist nurse at the Kidney Choices team. So she is fantastic, and it's great to have you back. Thank you for joining us tonight, Anne. I have to say, I usually say we're not nurses and doctors, but we do have a nurse in the house. We can't give any individual medical advice at all. The meeting is for information and educational purposes only. If you have any personal questions, do contact your own medical team. Now, it may be your high street pharmacist, it may be your GP, it may be your practice nurse or your renal team. But do, if you have a question, jot it down and ask them the next time you're along. And finally, we cannot recommend or promote any specific brands. So I mentioned if you didn't want to appear in a recording, what to do. But also you may want to ask a question after Anne's finished tonight. Some of you have already asked a question in advance, and we have a note of those from your registrations, and we will bring some of those out into the chat tonight. But if you are wanting to ask a question tonight, do use the chat facility. The chat facility you'll see, it's a little speech bubble. If you hit that icon, it opens up and you can type your question in there. There's also, as many of us using our work meetings and situations, our reactions, so you can raise a virtual hand. If you do that, we would come round to you and we would ask you to pop on your camera and also your microphone, and you can ask a question. But if you do wish to remain anonymous, please keep off your video. During the time that Anne is speaking for her short presentation, can we ask that you remain muted? Sometimes there can be background noise, and I know I can be a guilty party of having the barking dog. So if we can just do that, it is appreciated. If you have any questions from tonight, please do reach out to ourselves. You'll see our info@PKD Charity is on the screen, and we will drop that into the chat tonight as well. So finally, what I'll do is I'm just going to mute myself so you don't hear that barking dog, and I'll hand you over to Anne. Anne, if you'd like to take the floor.
Okay. Good evening, everybody. I work at Preston Hospital, and my main job is to support people who've got chronic kidney disease, usually when their kidney function is getting towards the point where they need to make decisions about treatments such as dialysis and transplant. So I'm aware that there's quite a few people on the call tonight who probably have very much better kidney function than the people I usually look after. So yeah, I'm going to try and keep that in mind while I'm here. But anemia is a huge symptom of kidney problems, and it's not something that everybody's really aware that is a problem when your kidneys start to work less than you'd like them to. So I just thought for the first slide, I'd just ask some questions based on what Susan asked me to talk about, and hopefully by the end of the session, I'll have answered most of the questions. So could we have the next slide, please? We'll talk first about what is anemia, and then symptoms, why do people develop anemia, what tests do we use, how is it treated, and hopefully we'll answer any questions at the end. So anemia is a condition where there's the amount of hemoglobin, which is a protein in red blood cells that carry oxygen around the body, is much lower than normal in your blood. And red blood cells, their job is to deliver oxygen to the tissues and organs of the body, and oxygen is then used to convert nutrients into energy. So the red blood cells are absolutely vital to everything that our body does. And the hemoglobin, the protein, is made up of iron. So as well as it's essential to have a good stores of iron in the body to prevent you from being anemic. And often the reason for anemia is that people are not absorbing iron very well from their diet or from any tablets or supplements that they might be having. And when you've got less hemoglobin and less red blood cells in your body, then your heart's having to work harder to deliver the oxygen. And if that carries on for any length of time, it's not going to be, we're asking your heart to work harder permanently. And there's a chance that, you might develop some symptoms of heart failure, which is absolutely not what we want. Now, I put normal hemoglobin levels on this slide. Men have slightly larger amounts of hemoglobin in the body than women do, but we would never seek to correct hemoglobin back to normal levels, if you like, because to do that, we usually lose control of blood pressure, which is a key goal of treatment, is to try and keep blood pressure well controlled in people with kidney disease. And we have a target hemoglobin for people who've got CKD who are on treatment for anemia between 100 and 120. Now, if you have hemoglobin that's higher than that without any treatment, that's not a problem. And if you're only on iron supplements, things like that, then it really isn't a problem if you've got a higher target hemoglobin, higher than the target hemoglobin. And if it's around 120, 130, we're okay. But if it's going really high and you're on treatment, we would probably be reducing the amount of things that we give you to treat anemia, because we wouldn't want the hemoglobin to get too high, because we put you at risk of high blood pressure and increased risk of stroke, which is, again, the last thing we want to do. That's the next slide, please. So looking at symptoms, people notice tiredness, lack of energy. Some people describe headaches, dizziness, and people easily get short of breath. And I was talking to somebody in clinic last week who's developed quite severe anemia. He's new to our service and he's in his late 80s, but he's very fit normally, and he's really struggling with, shortness of breath. And, I used to be able to walk a mile, and I can't, I'm really struggling now. And so it's been quite devastating for him. A lot of people also feel cold. So we have the battle of the thermostats, because, you've got the rest of the house saying, heavens, the heating's up to tropical, and the person who's anemic is sat there under lots of blankets and throws and feeling really cold all the time. And that can also be a symptom of low iron levels too. Some people get heart palpitations, because, again, that's because the heart's having to work harder. So you might see an increase in your pulse rate. Not many people are aware of what their pulse rate is, really, unless you've got one of those smart watches. But palpitations can be really unpleasant, because they feel like your heart's pounding out of your chest. And again, when you're moving around, and it's amazing how much more oxygen our muscles need when we're walking around. We don't need to be running a marathon. It's, palpitations can come on when you're really, really anemic. So it's something that people would notice. And altogether, these symptoms just make life more demanding. People struggle to do everyday tasks. And, people's physical and mental health start to suffer as a result. And thinking back to when I started nursing, and some of these treatments were sort of started to be around in the late 80s, and before then people with kidney disease had to really struggle with chronic anemia, because we didn't have any of these treatments. And the only thing that we would give would be a blood transfusion, which is absolutely the last resort now. Yeah. So when we're talking to people about what kidneys do, healthy kidneys do much more than filter toxins from the blood and regulate fluid, and that's that's a key message from today, really, that they make a hormone called erythropoietin, which is like a chemical message that goes from the kidneys in the back to stimulate bone marrow production to make red blood cells. It's the thigh bones in the legs are where the most of the red blood cells are made. So it's a bit like a stimulate, it's just stimulating, come on, make some red blood cells. That's what that hormone is doing. And we can't really measure EPO in the blood. So we tend to measure hemoglobin, which is really easy to measure. And when the kidney function gets worse, sometimes the kidneys fail to produce enough of this EPO or stop making it altogether. Now, people with polycystic kidney disease tend to carry on producing EPO better than people who've got kidney disease due to other causes. But you can also have problems with things like ruptured cysts and heady, horrible bleeds, significant bleeds from ruptured cysts. And obviously that would cause an acute drop in the hemoglobin, and then you might need some treatment. So there's other things as well, because obviously a significant bleed would cause a drop in hemoglobin too. And then people with reduced kidney function don't always absorb iron from their diet very well, and their iron stores drop. So even if the kidneys are making enough red blood cells, they're being stimulated to make enough red blood cells by an adequate supply of EPO from the kidneys. If you're short on iron, your body hasn't got the building blocks to make the red blood cells. And what you've also got to remember is that the existing red blood cells are living in a more toxic environment, like a toxic soup almost, because the toxins in the blood are higher, because the kidney function is lower. And normally red blood cells last about 3 months, and they can actually die off in about 6 weeks. So you actually need more red blood cells and a continuing supply being made. So your red blood cells, do die off quicker when in somebody who's got normal kidney function. Could I have the next slide, please? So we're looking at hemoglobin. That's really easy to measure. And obviously, if the hemoglobin is less than 100, that's usually the trigger point where people start to need treatment. We look at ferritin, and we also look at transferrin, and there's a few other tests that we use. There's about 4 or 5 really, and it's no good treating anemia. The first stage of the treatment is always, have you got enough iron? Because if you haven't got enough iron and your hemoglobin is below target level, we need to replace the iron first, because giving hormone treatments like EPO is not going to work if you haven't got enough iron in the body to make the red blood cells in the first place. And also, people who've got chronic kidney disease tend to have inflammation in the body that can affect how the body handles iron. So it can make it harder for your body to access iron stores within the body, even if you've got what looks like adequate iron stores. That is very complicated, and I leave that all of those kind of questions to my anemia colleagues, because anemia is, although it's something that I come across quite regularly, I'm not a nurse prescriber, unlike my colleague Rachel at Kendall, and it's her that does the prescriptions for anemia for our patients. So there's quite a few things going on really. So the first line treatment is iron supplements, and we can give those as tablets, but often people don't tolerate tablets very well. Iron tablets can cause really unpleasant side effects, usually horrible stomach cramps. People can find that they're affected by episodes of constipation or diarrhea. People have horrible black smelly stools, and if any of those things are happening, then iron tablets are not for you. And the best way of giving iron is usually by infusion, which, depending on how depleted you are on iron, you might need 3 or 4 of those in a calendar year, which isn't too bad. And you usually get that at a hospital. The first infusions given over about half an hour, and subsequent ones can be given over as little as 15 to 20 minutes. And iron injections used to be given like intramuscular injections, and they were quite unpleasant. There was a high risk of people having reacting to those, and that doesn't tend to happen as much now. And in the main, most people tolerate iron infusions very well. Any kind of drug reaction is quite rare. We don't see that very often at all. And also the other thing that we need to think about is there's a few other things, the vitamin B12 and folate, and sometimes people who prescribe the tablets to boost those because they are also needed as well as the iron to make hemoglobin. And then recently, there's EPO is given as an injection under the skin in the abdomen, usually every month. It can be given more frequently if the anemia is severe. So that is the same hormone that healthy kidneys make that tells the bone marrow to make red blood cells. And we can make that in a lab now, and that is the revelation really that's happened in the last 40 years, because without that we didn't have the ability to boost red blood cell production within the body. We could only give you iron supplements, and as well as the Aranesp, which is usually what we use for the EPO injections, we've also got tablets now. Now, that's horrendous, that hypoxia inducible factor. I can't even say it, but basically we use tablets such as roxadustat, which have become available quite recently. And as an alternative to an injection, these make your body think that you're living at altitude so that you will produce more red blood cells. And people usually take them 3 times a week. So it's on the same days, every alternate day, Monday, Wednesday, Friday. And then people don't need the EPO injections. They just need a good source of iron, make sure that they've got their iron stores topped up, and then they take the roxadustat tablets. Now, some people have noticed that their blood pressure starts to become a little bit higher when they've started roxadustat. Some people, again, a few gut issues, a bit similar to the iron tablets, has been noticed with roxadustat, but they are being used more and more. So don't be surprised if in the future you might be asked to take those by your nephrologist. And when we're talking about people with polycystic kidney disease, if you're struggling with things like ruptured cysts or infected cysts, it's particularly infection after pyelonephritis or a really severe urinary tract infection, EPO injections don't tend to work properly when infection's present, but the roxadustat seems to keep the hemoglobin and the iron stores really stable even at times of infection. So these new tablets really have got some good advantages for polycystic kidney disease. And when I was talking to our clinical director the other day, he started using them quite regularly for quite a few of his patients up in Morecambe Bay who've got polycystic kidney disease, and he says it's keeping their hemoglobin much more stable than the standard EPO injections that we've been used to using for the last few decades. Obviously, blood transfusions are given as a last resort, but if your hemoglobin's only 40, you're not going to be well at all. And we need to make sure that sometimes we do give a blood transfusion, but obviously we try and avoid these because it can make your chances of transplantation a bit more complicated. You produce antibodies, and it would only be ever given as a last resort. And to be honest, we don't really tend to use blood transfusions at all. But I just thought I'd put that there because sometimes we have to, because anemia is when you're really, really unwell and you've lost a lot of blood, we have no choice. So I hope that gives you a flavour of what it's quite complicated, and it's some of that might be quite new to some of you, but hopefully if you've got any questions, I'll be able to answer them in the the rest of the presentation.
Thank you so much for that, Anne. I found it informative. I have actually, there was a couple of things that I went, oh, I loved your description of toxic soup.
No.
That
Yeah.
really
I
helped
talk to
me.
that. Yeah, I talk to that tell my patients that quite a lot.
Yeah, because it made sense to myself about
Mhm.
how these red blood cells don't have what I would call the natural shelf life you would expect.
That's it. That's
Yeah.
exactly right. So you actually need
Uh-huh.
more than the average
Yeah.
person. Yeah. Yeah.
Uh-huh. Uh-huh.
That turnover of red blood cell production needs to be much more. Mm.
Mm-hmm, mm-hmm. No, it is. So just if anyone's wanting to ask some questions, do pop them in the chat. I see there's one in there already. And we were laughing about no specific questions, but it might help us just get a general understanding, right? Someone has low ferritin
Hmm.
levels with normal hemoglobin,
Yeah. Okay.
and it's
Well,
not considered
that's
anemia.
probably
And
not
that's
the
where we get
that's
into the terminology.
no, that's all right. That's not too much of a problem. But what we would do is we would suggest that they start to have some iron supplementation, because eventually, remember, the EPO that's, you've probably, that tells me that you've probably still got enough natural EPO coming from the kidneys, which is the chemical message that tells the bone marrow and the thigh bone to make red blood cells. But if your kidneys are still producing enough of that, then you're at some point when the ferritin is low, your body's not going to have the building blocks to make the red blood cells, so your hemoglobin will eventually start to drop. So we would always supplement iron first, and ferritin being low is not the only thing that we measure. There's transferrin saturations as well. So ferritin we try and keep about 100, and transferrin saturations above 20%. But as I say, there's short, medium, and long-term stores of iron within the body. And depending on what's going on, it can be hard for the body to access some of those stores. So the most obvious thing will be to make sure that the iron is supplemented either as tablets, and some people tolerate them all right, but usually as an infusion.
Perfect. Thank you for that detailed answer there. There's one coming in the chat as well. Someone believes they've got the symptoms of anemia, but their hemoglobin levels are fine. So that
Yeah.
might come back because you said we store iron in different things. I think that might be
Yeah, and
related.
also some of the symptoms that people describe, such as feeling cold or a bit tired, might mean that even if their hemoglobin is within a normal range, the target range, say 100 to 120, then you would definitely need some, you wouldn't necessarily need the EPO or the roxadustat, but you would need iron first. That's always the first line thing.
Thank you.
Trying to look at that other one as well.
And
Yeah, I was
Claire's coming in
distracted.
asking about increasing iron rich foods before medications. And we know that there was a lot of questions in advance relating to diet. And can we
Yeah.
improve our diet so we don't have to take medication if we were anemic?
Yeah, sometimes that works. I always remember the things about everybody used to say that if you were a bit anemic, eat steak and oranges. I don't know whether you've heard that one, but obviously it depends on what your kidney function is like. But a lot of our patients have to restrict the minerals in their diet, like potassium. And orange juice is notorious for, and vitamin C is also notorious for aiding people to absorb more iron from their food. But a lot of the, again, having low kidney function makes people's bodies, it doesn't work as well. So you don't absorb iron from food in much the same way that some people don't absorb iron from iron tablets very well. So, and lots of people have a cup of tea with their iron tablets, and the tannins in the tea can inhibit the absorption of the iron. So, but to be honest, I would say all the iron-rich foods like liver and things like that, a lot of people don't like them, but they're not always compatible with a kidney diet. So just be a bit careful, because I don't think that you would be able to supplement your iron enough if you were short on it
Mhm.
on diet alone, you would need usually infusions to keep the iron levels at a good level.
Thank you for that sensible advice there. And someone's asked, because tonight we've concentrated very much on, if you can say, PKD patients and those perhaps who've got lower function. We've not given any comment to those who are post-transplant.
No, that's
So
true.
someone said, is anemia treatment different for those who've had a transplant?
It's not the same, but it can be a bit more challenging because remember, when you've had a kidney transplant, and perhaps your transplant isn't working as well as you'd like it to anymore, but you're still on the immunosuppression to stop your immune system rejecting the kidney. Remember that the tablets that you're taking to stop kidney rejection are also damping down your immune system, which is basically your bone marrow. So we see a lot of people who've got a kidney transplant might need actually more in the way of RNSP injections, because they might need higher doses of those things. They might need higher doses of things like roxadustat because their bone marrow is at once being suppressed, but then on the other hand, you're wanting to boost the bone marrow to try and make more red blood cells. So you can be working, against what you're trying to do with the immunosuppression side of things as well. So we definitely leave that to the experts like a nephrologist and an anemia specialist nurse like my colleague.
So Posey's asking here, is there any particular stage of chronic kidney disease where anemia starts to come into play, or does it vary from person to person?
It does vary from person to person. I mean, people can have start to notice that they develop anemia at quite an early stage. But in the main, if your kidney functions sort of, above 20%, EGFR 20 mils a minute or more, we don't tend to see that much anemia. We might see low iron, but we don't tend to see hemoglobins that are too low. But when people start to notice, their GFR is below 15, they often need anemia treatment much earlier than you need dialysis, because dialysis, your kidney functions usually down to between 5 and 8% before you need dialysis. But people need anemia treatment much earlier than that.
And this is someone, if taking iron supplements, various humanity. My pronunciation's terrible. Someone else will be laughing in the background going, she can't say it. Various so it's FERROUS. And the second word, it's FUMARATE.
Ferrous yeah.
Thank you.
Ferrous fumarate.
But the levels aren't correcting, e.g., the hemoglobin, etc.
So that if they're not being effective, then you're not absorbing the iron from the ferrous fumarate, ferrous sulfate, whatever you're taking. So I would say that just forget the iron tablets, and you need intravenous iron. Yeah,
thank you.
Yeah, that's the best way of giving it. I saw something about a veggie as well.
I'm just trying to scroll down. busy screen here.
I'll do that one. I have low iron and PKD with good kidney function, but with symptoms of anemia. I've just been prescribed iron tablets, which are awful. My question is my anemia caused by the PKD, or is it just a case that I have low iron as I'm a veggie?
No, it'll be most likely the PKD. I mean, there is some suggestions that people, who are vegetarian, have lower iron, but I would, and again, I would say that it's definitely down to the PKD. And if you're not tolerating the iron tablets, and again, remember, the reduced kidney function may be affecting your body's ability to absorb iron from food, or in the same way that it makes you sometimes iron tablets on their own. They're often a first line treatment, but they're not effective for everybody, and a lot of people don't tolerate them well. So I know Rachel just often says, oh, she says, you know, that they're not tolerating iron tablets, forget it, just go straight to iron infusions, and that's what she does. Yeah.
And I think we've got Amy in the audience, and Amy's maybe worrying in case this is a guarantee that as a PKD patient, she will at some stage become anemic. Is it a guarantee?
No, it isn't actually.
Yeah.
No, it isn't, because I mean, I see quite a few people with polycystic kidneys who never need anemia treatment. No, they don't. They still produce a lot of EPO, and you know, they might need some iron supplementation. They might need some iron infusions, but they certainly don't need EPO or roxadustat. So, and you know, if their hemoglobin is good, you know, if it hasn't broke, don't fix it. You know, you don't need EPO if your hemoglobin's consistently, you know, within target of 100, 120 or beyond, because as I say, if it's naturally higher than the target, with no RNS or roxadustat needed, then that is absolutely fine. That's not going to affect your blood pressure. That's not going to put you at increased risk of stroke, because we're not asking your body to make red blood cells and make your blood stickier and thicker, because you know your body's doing that itself. We're not, you know, enhancing the amount of red blood cells you've got from treatment. All we're doing is supplementing iron, and your body will do that itself. You know, we just need to supplement the iron, and that's sometimes all that's needed. And sometimes people don't even need that.
And someone's commented in the chat there about their blood test. When they see it written quite often, the hemoglobin, it's an estimation, the value of the test.
Yes.
Yeah. And how accurate is it?
It's usually pretty straightforward to you know, to the hemoglobin is usually pretty accurate. I mean, as I say, it's when you see a full blood count, there's lots of red blood cells. There's also the other things that some people look at as well is reticulocytes, which are immature red blood cells. And for more complex things, if people aren't responding to treatments, you might look at those a little bit more. But to be honest, I'd say that that's not going to be a problem for a lot of the people on this call. And as I say, not everybody has anemia, so that's good. But
someone in the chat is praising their first infusion.
Good.
Their comment is, I've had my first infusion. It's been great.
Yeah.
But followed up with, how often will I get them?
Yeah. It varies, because remember, if somebody, for example, is very anemic, you know, maybe their hemoglobin's gone down to 86 or something like that, and that's not because of a bleed, that's just because their kidneys are no longer capable of making this EPO anymore. And what might happen for them is that you've supplemented their iron, and that's they were low on iron, and that in itself is sometimes enough. But if you're stimulating the bone marrow to make more red blood cells by giving the roxadustat tablets or the RNS injections, your body is going to need more iron to carry on making those red blood cells. So you're going to use up more iron. So your demand for iron is going to go up if you are on roxadustat or the RNS. So I would say that on average, I usually advise people that they might need between 2 and 4 infusions in a calendar year. But some people might need a little bit more than that. And that's not a problem. It just means you have to go for more appointments, obviously. But at least we can carry on giving the infusions. And keep an eye on. And usually we check bloods. Obviously, when people are on the RNS or the roxadustat and they're starting these treatments, we would be doing regular blood tests, full blood count, checking the hemoglobin, probably every 4 weeks, something like that. 3 weeks, I think it's they would check those within 3 weeks of starting the treatment. But it's usually every 3 months that we check iron stores. And obviously they're going to be really high if you just had one. So there's no point checking them if you just had an iron infusion. But obviously, if you know, within a few months, the iron stores have probably been used up and you might need some more.
I'm just thinking it's great that Alison's had that positive effect for so many when you're on a call like this. You're hearing about
very,
these
very
treatments,
good.
but
Yeah.
that's someone
Yeah.
positive there. So if anybody else has a positive comment about their iron treatment, pop it in the chat and we can share it with some of the others, or you can read through them. Alison, thank you so much for popping that little link in there and reminding me that we do have recordings available of similar chats like this, tonight's event on many topics, and we will share that, but the link is there in the chat and I'll share that again with everyone tomorrow. Is there anything catching your eye there, Alison?
Yes, I was just looking and saw that somebody was asking, I've just had my first iron infusion, but it didn't increase my hemoglobin. I'm due to start EPO, which terrifies me. I really hope it makes me feel better because I'm struggling with fatigue.
Yeah. I mean, usually, you know, sometimes iron, you know, on its own it's the first line treatment, but it's not always effective on its own, because that might be that your kidneys are no longer producing enough EPO. So the bone marrow is not being stimulated enough to make red blood cells, even though you've now had an iron infusion. So you've got the iron there, you just haven't got the hormone to stimulate the production of the red blood cells. EPO injections, they're not complicated. Usually they're given in a, you know, by pinching an inch on in your abdomen, and I've got plenty to pinch, but some of you might not do. And it just goes under the skin, and they're pre-filled syringes, so they're not, you know, there's no drawing up anything. They're all you just peel open the packet, and the syringe is there ready to use, and it actually clicks when it's delivered the full dose. Some people, obviously it's a big thing to inject themselves, but it's not the, you know, EPO injections aren't the only treatment now. You know, some people you know, might tolerate roxadustat, the tablets, and they are being used more and more. And that is obviously, you don't need both. You know, some people are quite happy with the iron-esp injections, but other people might benefit more from the tablets, because they're you know, they've got some natural EPO, but it's just asking your they make your body think that you're living at altitude, and they will, you know, increase the turnover of red blood cell production. So roxadustat is an alternative to iron-esp, but it's, you know, it doesn't work for everybody. So talk to your nurse. You know, honestly, there's some people go to the practice nurse for it. Some people just get a significant other to do it if they're a bit squeamish with needles. But honestly, it is the benefits are amazing, because when you think back to the times where we didn't have any of these treatments, you know, people were living in limbo because they had such, you know, hemoglobins of 70 and 80, and just horrible. You know, living a half life, and it's it's really not complicated.
And also Dawn's just commented and she's been using EPO herself, and she's just reassuring everybody who's thinking that they might need to take it that she found it quite easy to do, and was fully shown how to do it by a kidney nurse, and it was absolutely fine. So thanks very much, Dawn, for putting other people's minds at rest.
I'm glad you had that experience, Dawn. I really am. Good.
I'm giggling at that. My own husband had a period in his PKD journey where he took EPO injections, and this was the man that was struggling with a paracetamol. Eventually, he was fantastic. He used to just inject into his thigh, actually. It was over and done with. Just that click.
For you,
and it was over and done with, and it shocked me. And I now call EPO the magic medicine that enabled him to work and pay the mortgage. It was the notice and improvement on him. And you could almost say, now, for instance, I think it might have been 21 days apart treatments. I can't remember now. but you could almost say by day 18, you're needing your jab. When is it? It was the magic medicine.
Good.
Yeah.
Good.
So what else is coming in there?
I think we've got one more that was delivered quite early on, but we had a flurry. We might have missed it, from Jonathan, who said that was great presentation. If your level of hemoglobin is low, below 100, then you can start the injections if your iron levels are good. Is that right? Also,
if you've had iron if you've got normal iron levels and your hemoglobin is below 100, then that would be a point where you might need to start either roxadustat or the Aranesp. So yes, yeah, because the first thing to do is to make sure that your iron stores are good, because if your iron levels are low, there's no point adding another treatment.
Okay. And he'd also asked, at what level do you start having problems? As I've always been anemic, but my EGFR is not that low. No.
Well, I mean, as I say, it just depends on how much EPO that your kidneys are producing.
Yeah.
And it's all about, hemoglobin is, if it's below 100, you would be looking, the first question to ask is, have we done any iron levels? What's the ferritin? What's the transferrin saturation? Look at B12 and folate, remember, as well, because if people are low on those, sometimes they are also crucial for making healthy red blood cells. So if you're deficient in B12 or folate, you might need some tablets for that.
That's great.
And someone was mentioning the difference between iron medications or the treatment as a tablet or a liquid form.
Oh right, yes, because you obviously can get the things like the stuff in the bottles that you see, Floridex or something. I can't remember what it's called. To be honest, we don't tend to use the liquid iron. You don't ever see a nephrologist prescribing that. Some people obviously take them because you can buy them over the counter, but I would definitely be a bit skeptical about anything like that, because if you're not absorbing iron from tablets, or you're not going to absorb it any easier from liquid, it really isn't. It's not no better really. And a lot of people, what you've got to remember is that these like Floridex things that you see advertised in magazines and things, they're for the worried well, as I call them. They're not. A lot of people are probably taking too much iron if they don't actually need it. And when you've got normal kidney function, you can get rid of stuff. Whereas if you've got reduced kidney function, any tablet, well, whatever it's going to do for you, is going to stay around a lot longer in your body, because your kidneys don't process things as quickly because they're not working as well. So I would definitely say that we don't bother with the liquid iron or the iron tablets. I would usually, most people, it's just better to give IV iron. Yeah, a bit more of a hassle in terms of an appointment. But if you're not tolerating oral iron, go for IV iron. But if you are tolerating it, absolutely fine.
And that's a perfect time to bring in Nina's question. Nina is asking, are iron infusions appropriate for people who still have okay function, e.g. in the 50s? Or is it more for those with lower function?
I would say that most people who were having intravenous iron would have a lot lower GFR than in the 50s. Yes.
And also following on at that question, she then goes on to talk about the target being 100 to 120 for hemoglobin.
Hemoglobin, that's right. Yeah. And ferritin, you're looking for a ferritin of above 100, ideally. But remember, infection can also make ferritin look very, very high. Some people have liver problems, which can also affect the ferritin levels. So it's looking at blood results simplistically not the whole story. You leave it to your consultant and look at the whole thing, because there's usually about 4 or 5 things on a blood test that they're looking at to actually decide whether you need iron supplement.
So that's perfect,
iron.
maybe for Andrea, who's asking, sorry, what's the normal range for ferritin?
Yeah, you want it to be above 100.
Yeah.
Yeah. Yeah.
But it is, it's not in isolation, it's when you look
No,
at all
you've
the
got to look
things.
at, yeah.
Alison, can you see anything there?
I can't see any more. I think we've gone through all of the questions that there've been, and I think we've covered quite a few of the themes that came up in the questions that were asked previously.
Yeah.
Does anybody else have any further questions? If so, if you'd like to put them in the chat, you need to do so pretty quickly.
Or if you're feeling brave, you can raise your hands, and we can.
It is easy to find information about anemia as well online. You know, other charities like Kidney Care UK produce some good booklets, and most people, if they're starting, you know, the RNS or the roxadustat tablets, there are some really good booklets that accompany those that you'll probably get from your anemia nurse when she's showing you how to do an RNS injections, for example. So, but there are some really decent anemia information on the kidney websites. So,
and I think that's it. And it's when it comes into play, if you are anemic, if your iron stores are low, you're usually seeing a nurse like yourself in clinic who welcomes the questions and the chat about it, and will have a little bit more time to perhaps explain what it is exactly for that patient.
Yes.
And it's just messages of thanks coming through, which are lovely to see.
You're welcome. I was just looking at me that thing about the ferritin is usually micrograms per litre, so it's more, you want it to be greater than 100 micrograms per litre, so that's mcg/L is what the units are usually.
Right, perfect. And I was about to ask something, and somebody's brought something to the top of the feed there, so I've lost it. Ruth is wondering, quite often we talk about reasonable adjustments within the workplace, etc. And would chronic anemia be recognised as something for a reasonable adjustment?
I would say so. It depends on how anemic you are. And obviously everybody's different, because some people can operate at a hemoglobin of, you know, I've seen people whose hemoglobins are really low, you know, before they start treatment, you know, in the 80s, and you know, perhaps they're not feeling too bad, whereas you see other people whose hemoglobins dropped to say 95 and they're really feeling you know, struggling to cope with everyday tasks. So it's and obviously anemia is a lot of people don't realize things like restless legs. If you've got restless legs, or sometimes even itchy, prickly skin can be a sign of like low iron or low hemoglobin, which some people get, and other people look at you like as if to say, "What? I've never had that," you know. But symptoms are very variable in some people. I mean, the tiredness is the big thing that resonates with virtually everybody, but obviously tiredness is massive, you know, and it depends on how strenuous your job is too, because some jobs are very physical, some jobs are, you know, much more sedentary. But and again, sleep can be affected by restless legs, you know, and some other symptoms that people are experiencing with low kidney function, or, you know, you're struggling with infection or you know, pain. You're not sleeping, so all of those things impact as well, because you know, if you're not sleeping very well, and it's like the menopause thing, isn't it? A lot of people don't sleep very well, and there's nothing wrong with their kidneys, but people get reasonable adjustment for the menopause. So I'd certainly say that you get reasonable adjustment for chronic anemia.
And Ruth, you followed up with what adjustments. They're so individual. For some people, it may be working from home for a period of time, an extended lunch break. Others, it may be a later start to avoid the peak commute. So there's many, many things that employers can do. So perhaps an open discussion might be the best thing there. Again, lovely comments. Oh, someone's just over that magic 100 that we've mentioned. We keep saying number 100. My hemoglobin levels are 106. Do I need to take iron supplements to increase this?
I would say ask your doctors, or your nurses, what your iron stores are like, because if that's if your hemoglobin has started to reduce, it might be a sign that you need some iron supplements. So we wouldn't actually start anybody with a hemoglobin of 106 on anything like IronEsp, but you might need some iron. So I'd definitely ask what the iron levels are first.
And Andrea's just put a little message of thanks in, and I'm sure she's speaking on behalf of many. Thank you so much for your fantastically reassuring and informative webinar.